Welcome to eNormous Nephrology. This is the 8th session or the final session of 8 sessions of board review designed to help the upcoming clinical practitioner or medical student or anybody at any level of their medical careers prioritize areas needing further study as one progresses towards betterment in clinical practice or towards the boards. All of my videos will be present at youtube.com/@irfanmoindeen-kidney, and they include videos requested by viewers as well as videos on topics of special interest to me. So in nephrology, we always begin with a urinalysis. And you would suspect glomerulonephritis if there's proteinuria and or hematuria. If you have proteinuria plus microscopic hematuria, you can suspect nephrotic syndromes, which we discussed in earlier sessions of this board review series. If you have proteinuria without microscopic hematuria and the quantity of protein is significant enough, which we'll discuss in the next slide, you should consider nephrotic syndromes. Nephrotic syndrome is defined as persistent proteinuria greater than or equal to 3.5 grams per day in adults or greater than or equal to 40 milligrams per hour per meter squared in children. In combination with low albumin, less than 3.5 grams per deciliter, with additional features which may be present, including edema, which may manifest as peripheral edema or ascites or pleural effusions. And the reason nephrotic syndrome is typically an edematous state is because there is sodium retention. Nephrotic syndrome is a state of sodium retention, as well as usually the albumin is low enough such that the oncotic pressure is very low, and fluid leaks into the interstitium, resulting in edema. You may have hyperlipidemia because you have so much protein loss that the liver is working in overdrive, and so the liver is making lots of protein, but among those proteins are lipoproteins and lipids. So you have resultant hyperlipidemia. You may have hypercoagulability because amongst the proteins that are lost in the urine are proteins such as antithrombin 3. And loss of these proteins will result in a hypercoagulable state. Nephrotic syndromes can have secondary causes, which are known causes, or they may be idiopathic, which are known as primary nephrotic syndromes. And these are typically the primary podocytopathies, such as minimal change disease, focal segmental glomerulosclerosis, and membranous nephropathy. Now, each of these has secondary causes. So there's secondary minimal change disease, secondary FSGS, and secondary membranous nephropathy. Amongst the other secondary causes of nephrotic syndromes is diabetic kidney disease, and then amyloidosis and non-albumin proteinuria syndromes. We will discuss diabetic kidney disease in a brief overview. I will devote a special session to non-albumin proteinuria. So let's begin our discussion of nephrotic syndromes. In the urine, you may see lipiduria, fatty casts, and oval fat bodies. Lipid-laden macrophages in nephrotic syndrome can result in Maltese crosses, which can be seen in polarized light, such as here. Lipids that enter the tubule are, to some extent, absorbed by kidney tubular epithelial cells and macrophages. The intracellular lipids coalesce into refractile globules within the tubular cells, forming what are called oval fat bodies. As these lipid-engorged tubular cells slough from the tubule, they appear in the urine, either free or within casts. Lipid casts are the result of accumulated free lipid droplets or lipids released from degenerating oval fat bodies, which is what you see here. Although less common, cholesterol crystals may form and appear in refrigerated specimens. Dysmorphic red blood cells can be seen if there is a combined nephrotic process. Nephrotic syndrome typically does not have hematuria, as I said earlier, so you will not see dysmorphic red blood cells. However, if it's a combined nephrotic process, you will have hematuria, and those red blood cells will be dysmorphic. Dysmorphic red blood cells are red blood cells that pass through or traverse the glomerular basement membrane and are therefore modified in the process. Now, that modification can be non-specific, and you can just have a distorted red blood cell, or you can have a specific dysmorphic red blood cell, which is very sensitive for glomerulonephritis. Now, the glomerular basement membrane is 300 to 400 nanometers, and the red blood cell is 7 micrometers. The dysmorphic red cell is about 52% sensitive and 98% specific. The specific dysmorphic red blood cell that we're interested in is a red blood cell with a bleb on it. And there's one here, which has a small round bleb on the red blood cell. This one is also somewhat typical with the bleb on the red blood cell. So those types of dysmorphic red blood cells are very useful in determining if there's a nephritic process that is present. Let's talk about minimal change disease. Minimal change disease affects mainly children, 90%, and less commonly adults, 10%. The reason it's called minimal change disease is because there are minimal changes or no changes on light microscopy. But in reality, of course, there's always going to be a little bit of change. So minimal is probably a better term. In fact, that's the title of the disease, minimal change disease. Immunofluorescence will have negative or scant immunoglobulin deposition, and electron microscopy will have diffuse foot process effacement. Secondary causes of minimal change disease include drugs such as NSAIDs, neoplasms, typically lymphomas and hematologic malignancies, some infections, and allergies. Majority of minimal change cases are idiopathic or primary. So just for reference, I did put a normal glomerulus in here. And you can see that the capillaries are all open, which is why you see that white stuff in the glomerulus. That's the lumen of the capillary without any inflammatory cells. And then the pink stuff is the mesangium, which is normal, not expanded. It's not overly or excessively pink, and not excessively cellular. And by excessively cellular or mesangial proliferation, we mean more than 4 cells in any contiguous segment of mesangial matrix. So you can see that at most you have 2 or 3 in each contiguous segment of mesangial matrix. So this is a normal glomerulus. I just wanted to show you normal and abnormal foot processes. So obviously these are electron microscopies, and this shows you the glomerular basement membrane. And these are the foot processes that are adjacent to the glomerular basement membrane. And those foot processes are what form the slit diaphragm, and they prevent proteinuria or leakage of the protein into the tubules, into the urine. So this is a normal morphology of foot processes. These foot processes in nephrotic syndromes are effaced, and therefore lack of foot processes will lead to or contribute to proteinuria. This is minimal change disease, and you can see that there's a few foot processes, but for the most part, the foot processes are effaced. This is minimal membranous nephropathy, and you can see here this slightly dark area in the glomerular membrane. This is the subepithelial area because the foot processes are epithelial cells. So in the subepithelial region, you have these immune complexes, which are typical of membranous nephropathy. And for the most part, the foot processes are effaced. This is the same thing, except we're a little bit zoomed out. And here you can see that if foot processes are pretty much effaced in the area where you would see the epithelial cells or the podocytes. So what causes minimal change disease? The proposed mechanism is that there's secretion of a permeability factor that damages podocytes. And the search for that permeability factor is ongoing, but has somewhat been elusive. In a subset of minimal change disease patients, a nephrin autoantibody has been found. In one study, 18 out of 62 patients had circulating nephrin autoantibodies, and these decreased or were absent after treatment, resulted in partial or complete remission. These patients had fine IgG antinephrin staining on immunofluorescence. And the hypothesis is that antinephrin immunoglobulins may bind to nephrin in situ and disrupt the integrity of the slit diaphragm with resultant podocytopathy and proteinuria. How do you treat minimal change disease? In children, there's a 2019 randomized controlled trial of 237 children with steroid-sensitive nephrotic syndrome, and they treated for 8 weeks versus 16 weeks of prednisolone, and that had similar efficacy and rates of relapse. Long-term side effects were not studied. In adults, the evidence is not so robust. Traditionally, minimal change disease has been treated with greater than or equal to 3 months of steroids. And retrospective studies suggest longer duration is associated with more patients entering remission. Alternate day steroid therapy and daily therapy have similar remissions, time to remission, relapse rate, and time to relapse. Of course, we're all interested in trying to spare patients from the toxicity of steroids. Calcineurin inhibitors have been used in adults with steroid-dependent or frequently relapsing minimal change disease, which is when the steroid exposure is the greatest with the repeated steroid use. So you would want to try to use an alternative agent in these patients. So a randomized clinical trial of 119 patients in which 10 days of IV methylprednisolone was followed by tacrolimus or prednisone. Tacrolimus was non-inferior to prednisone. Adverse events were more common in the prednisone group. And then there's a randomized controlled trial from the UK with 50 patients with de novo minimal change disease. There was a steroid-free protocol of tacrolimus versus prednisolone. and prednisolone was associated with earlier remission and non-significantly greater remission rate at 8 weeks, 84% versus 68%. However, there were similar rates of complete remission at 16 weeks and 26 weeks in both groups. Both groups had similar rates of relapse and similar rates of adverse events. But of course, the number of patients was small, and the study was likely underpowered. Use of tacrolimus as first-line agent in patients at higher risk of complications from steroids has been suggested. There's a randomized controlled trial of 120 children with steroid-dependent nephrotic syndrome from 2018. Rituximab with prednisolone for 4 weeks was studied versus tacrolimus with tapering alternate day prednisolone, which was stopped at 6 months in those without relapse. Ritux was more effective in maintaining remission, 90% versus 60% during 12 months of follow-up. The median time to relapse was 40 weeks for Ritux versus 29 weeks for tacrolimus. And the cumulative steroid dose was significantly lower in the Ritux-treated patients. So as far as steroid-sparing therapy, mycophenolate mofetil has been proposed as a second or third line agent. In children, it's inferior to cyclosporin. In adults, there was a randomized controlled trial of 119 patients with new onset minimal change disease. And they studied prednisone 1 milligram per kilogram per day versus prednisone 0.5 milligram per kilogram per day plus myfortic 720 milligrams twice daily over 24 weeks. Both had 60% complete remission at 4 weeks. There were similar rate of complete remission at 24 weeks and similar rates of relapse and adverse events. There may be a potential role of mycophenolate in reducing exposure to steroids. There have been good long-term outcomes in children with minimal change disease. Progression to ESRD is rare. And if there is progression or persistence of proteinuria, repeat biopsy commonly shows FSGS. Patients with frequently relapsing disease can experience osteoporosis, obesity, and hypertension due to steroid exposure. The outcomes in adults with minimal change disease are slightly less favorable. 50% respond to steroids and do not have recurrence, and 30% have frequently relapsing disease. Concomitant tubular injury is common. The best predictor of outcome is response to immunosuppression. And again, repeat biopsy commonly shows FSGS. In these patients, genetic testing should be considered to determine if there's a genetic basis, such as genetic FSGS. Let's talk about focal segmental glomerulosclerosis, or FSGS. So focal segmental glomerulosclerosis, the way it's named, you have a focal aspect and a segmental aspect. The focal aspect is that only focal portions of the kidney are affected, and the segmental aspect is that only a segment of the glomerulus is affected. So here you can see that the sclerosis is in a segment of the glomerulus. Again, FSGS can be secondary or primary. Primary assumes that it's idiopathic or that the cause is undetermined or sometimes as of yet undetermined. Secondary causes of FSGS include toxins, drugs such as permethrinate, viruses or infections, and then any process that results in hyperfiltration. This can be low nephron number, nephron loss, increased demand, as in obesity. Obesity is probably close to the number 2 reason why we see secondary FSGS. Solitary kidney, premature birth, low nephron number. Hypertension is a very common cause of FSGS, maybe number 1. Hypertension and obesity are by far the most common causes of secondary FSGS. And then genetic FSGS is due to mutations in podocyte genes or glomerular basement membrane collagen genes. FSGS lesions can be from post-inflammatory scarring of a proliferative or necrotizing lesion, such as lupus nephritis or ANCA vasculitis. Let's talk about pathogenesis of FSGS. Some investigators do propose that minimal change disease and FSGS are different histologic manifestations of the same disease process. So podocyte injury, the first thing is that you have podocyte injury, and this is followed by podocyte apoptosis and detachment. The denuded glomerular basement membrane comes into contact with parietal epithelial cells, resulting in a scar. The parietal epithelial cell may act as a progenitor and replace the lost podocytes. However, if podocyte depletion is extensive, repair may not be possible. The primary FSGS syndromes may be due to a soluble permeability factor. Secondary FSGS is thought to be because of a mismatch between glomerular demand and glomerular capacity to repair. Again, you have genetic FSGS, in which mutations in some genes may impair ability to maintain podocyte cytoskeleton, foot processes, slit diaphragm, or interaction between podocyte and glomerular basement membrane. How do you distinguish primary FSGS from secondary FSGS? In primary FSGS, you have diffuse foot process effacement, typically greater than 80%. Anything less is more likely consistent with secondary FSGS, and a secondary cause should be searched for. There are some exceptions. Collapsing FSGS due to HIV, interferon, or permethrinate therapy are characterized by widespread foot process effacement, even though it's a secondary FSGS. Light microscopy or electron microscopy cannot reliably distinguish genetic FSGS from primary FSGS. Secondary FSGS is treated by treating the underlying cause. RAS inhibition and SGLT2 inhibitors lower intraglomerular hypertension and should be used. Genetic FSGS does not have any specific treatments that are available. Immunosuppression should be avoided since response is suboptimal. One should focus on conservative measures such as weight loss, blood pressure control, and use of RAS blockade or SGLT2 inhibitors. Sparsentan or Filspari is approved by the US FDA to reduce proteinuria in adult and pediatric patients with FSGS without nephrotic syndrome. Sparsentan is basically ARB plus endothelin antagonist and is thought to be effective in FSGS, whether it's primary or secondary, as well as in IgA nephropathy. Primary FSGS or idiopathic FSGS or FSGS of undetermined cause can require a prolonged course of high-dose steroids, 1 milligram per kilogram for greater than or equal to 16 weeks. 30% will have a relapse, if patients do not respond after 16 weeks of therapy, calcineurin inhibitors should be considered. Calcineurin inhibitors can be used if there are contraindications to steroids, such as obesity, diabetes mellitus, or osteoporosis. Rituximab can be used in steroid-responsive patients who are steroid-dependent or who experience frequent relapse. Obinutuzumab is under investigation. Again, sparsentan or Filspari, which is a ARB plus endothelin antagonist, is thought to be effective in all forms of FSGS and IgA nephropathy. Let's talk about membranous nephropathy. The hallmark of membranous nephropathy is immune complexes in the subepithelial region of the glomeruli. And antigens are being discovered, newer antigens that will result in immune complexes which deposit in the subepithelial region of the glomeruli. The first antigen that was discovered, and that is the most common antigen, is the PLA2R antigen. And other antigens are just being discovered every day. But there are secondary causes of membranous nephropathy, and these secondary causes will also result in antigen-antibody immune complexes, and individual antigen associations are being found for most of these secondary causes. But amongst the secondary causes are sarcoidosis, malignancies. Anybody with membranous nephropathy should have age-appropriate cancer screening, and if they have symptoms like pain, those symptoms should be investigated. Sometimes imaging the area of the pain has been conducive in finding a cancerous process in that region. Autoimmune disease such as lupus membranous nephritis, infections such as hepatitis, syphilis, schistosomiasis, and medications. NSAIDs are a common cause of membranous nephropathy. Pamidronate is a cause of membranous nephropathy. So primary membranous nephropathy is one without a disease association. For example, the PLA2R antigen causes membranous nephropathy, but there is no disease association other than proteinuria and nephrotic syndrome. Both primary and secondary membranous nephropathy are likely due to autoantibodies against specific antigens on the podocyte surface or associated with overexpression of a specific antigen. Identifying the target antigen is recommended by mass spectroscopy, for instance. On light microscopy, you will see thickened glomerular basement membranes because of the immune complexes. And basically everything you see is because of those immune complexes. Those spikes are the immune complexes themselves. Holes are basically areas that are covered by immune complexes, which are preventing the stain from staining the glomerular basement membrane. So what you see is a hole in that region. And you can see glomerular basement membrane ruptures. Immunofluorescence will show intense granular staining for IgG, or if you stain specifically for PLA2R, you'll see granular staining for PLA2R along the glomerular capillary walls, and these are generally absent or faint in negative cases. On electron microscopy, you want to see those subepithelial immune complexes. So here is a light microscopy, and this is showing you areas of the glomerular basement membrane that are not stained. Therefore, they kind of look like holes. So for example, here you see that glomerular basement membrane is not stained, and there are other regions. Here is an area of the glomerular basement membrane that's not stained. So those kind of look like holes on light microscopy. Immunofluorescence has this granular staining of the glomerular basement membrane by IgG or PLA2R. So on electron microscopy, you want to see foot process effacement and subepithelial immune deposits. This is the glomerular basement membrane. And to this side, you should have the foot processes. And here you actually do not see those foot processes because they're effaced. And so the foot process or the podocyte is your epithelial cell, and your subepithelial area is where you're going to see the immune complexes, which is these dark areas. Those are the immune complexes seen on electron microscopy. That's classic for membranous nephropathy. Anti-PLA2R antibodies are very specific. PLA2R has not been detected in other GNs or in healthy control individuals. A few cases of secondary MN patients have had anti-PLA2R positivity, and this is thought to be due to primary membranous nephropathy who happen to have a secondary disease. Kidney biopsy can be deferred if anti-PLA2R antibodies are positive, GFR is greater than 60 milliliters per minute per body surface area, and secondary membranous nephropathy or diabetic nephropathy is unlikely. That's how sensitive and specific PLA2R is. As far as PLA2R, ELISA is commonly used for quantitative assessment. Cell-based direct immunofluorescence is sensitive and can detect low levels of anti-PLA2R antibodies. However, it's not quantitative. So ELISA is quantitative, but sometimes ELISA can be negative, but immunofluorescence can still detect very low levels of anti-PLA2R antibodies. So ideally, both ELISA and immunofluorescence should be used for initial diagnosis of membranous nephropathy. Low levels of anti-PLA2R antibody is associated with high rates of spontaneous remission. High levels of anti-PLA2R are associated with progressive loss of renal function. Declining levels of anti-PLA2R antibody is the best predictor of response and also has the best prognostic value. Immunological remission typically occurs much before clinical remission, which is decrease in proteinuria. Immunological remission is what you should see, and then clinical remission will happen later, sometimes much later. If anti-PLA2R antibodies do not decrease within 6 months, a change in immunosuppression should be considered. THSD7A was the second antigen that was found as a cause of membranous nephropathy, but subsequently many other antigens have been found, including NEL1, SEMA3B, PCD87, EXT, NCAM1, and FAT1. THSD7A is associated with a high rate of malignancy, and a search for malignancy is recommended. NEL1, the most common IgG identified was IgG1. In PLA2R, it's IgG4. 12% of patients had malignancy, so even in L1 patients, evaluation for malignancy is recommended. SEMA3B is common in pediatric cases and recurs post-transplant, so levels should be monitored post-transplant. PCD87 has some association with autoimmune disease, sarcoidosis, or malignancy. EXT/EXT2 is predominantly in female patients, and 70% had autoimmune disease, 35% had lupus. NCAM1 is overexpressed in membranous lupus. 25% had class 3 or 4 lupus nephritis as well. FAT1 is present in patients who have undergone hematopoietic stem cell transplantation. And This can occur years after transplant, particularly in patients with graft versus host disease. The goal in membranous nephropathy is immunological remission in PLA2R membranous nephropathy and clinical remission in others, i.e., decrease in proteinuria. If you know what the target antigen is, one can try to monitor the target antigen, but commercial assays are not commonly available, so that may be difficult. Low-risk patients may enter spontaneous remission, and that's why supportive therapy for 3 months is recommended, just in case one may be able to avoid immunosuppression. Supportive therapy consists of sodium restriction, low protein diet, blood pressure control, RAS blockade, and statin. Now, what is a low-risk patient? A low-risk patient is one with normal GFR or stable GFR over 6 months, proteinuria less than 4 grams per day, negative or low anti-PLA2R antibodies, i.e. 50 RU per ml, or PLA2R that are decreasing by greater than or equal to 25%. These patients should be monitored conservatively. High-risk patients must be treated, and then there are those moderate risk patients which should be treated if there's progression, such as if proteinuria increases, GFR declines, or the PLA2R titer increase. The moderate risk patient has a normal or stable GFR over the preceding 6 months, proteinuria between 4 to 8 grams per day, moderately elevated PLA2R, 50 to 150 RU per ml, that are stable over 6 months, and there is an absence of life-threatening complications such as thromboembolism. The high-risk patient who must be treated without an observation period would be the one with GFR decline greater than or equal to 25%, greater than 8 grams per 24-hour proteinuria, PLA2R greater than 150 RU per ml, or if there's a life-threatening complication. Rituximab is the most promising immunosuppressive treatment in membranous nephropathy. KDIGO recommends Ritux as first-line therapy. It is comparable to cyclophosphamide in achieving remission at 24 and 36 months. In the Mentor trial, this was a randomized trial which compared Ritux to cyclosporin. Ritux was non-inferior to cyclosporin in inducing remission at 12 months and was superior to cyclosporin in maintaining remission at 24 months. Ritux is non-inferior to cyclophosphamide. 30% of patients may not experience complete remission with rituximab. Obinutuzumab, a type 2 anti-CD20 agent, which leads to more potent B-cell depletion and may have a greater effect on memory B cells, is an option and is being compared to Ritux in an ongoing trial. In patients with already low GFR or decreasing kidney function, cyclophosphamide can be considered. Historically, cyclophosphamide and chlorambucil have been shown to be effective in patients with membranous nephropathy. We'll finish off with a discussion of diabetes mellitus. So we have to define some terms. Historically, several of these terms have kind of appeared in succession. Now, the term that's recommended to be used is diabetic kidney disease if chronic kidney disease is primarily due to chronic diabetes mellitus with proteinuria or without proteinuria, and these patients may have varying trajectories in renal function decline. But sometimes you can have diabetes and CKD, which may not necessarily be associated, You can have CKD due to other reasons in a patient who has diabetes. The term diabetes in CKD or CKD in diabetes has been recommended for patients with diabetes who may develop CKD due to either diabetic or non-diabetic lesions. The term diabetic nephropathy implies pathologic diagnosis, implies long-standing diabetes in conjunction with classic nodular Kimmelstein-Wilson nodules on kidney biopsy, arteriosclerosis, and arteriolar sclerosis. But of course, kidney biopsy is frequently not utilized in patients who are suspected to have diabetic kidney disease. So in the old days, there was a definition for diabetic nephropathy. So diabetic nephropathy was defined as type 1 diabetes with at least 10 years duration, or type 2 diabetes with macroalbuminuria, or type 2 diabetes with microalbuminuria plus retinopathy. This definition is not used anymore, and the terms macroalbuminuria and microalbuminuria have also fallen out of favor because albumin, the size of albumin does not change. You do not have a macroalbumin or a microalbumin, and it can be a very confusing term. Some clinicians or patients might assume that they have a small albumin size or a large albumin size, or that their condition is minor or major, but that's not what the term is supposed to convey. So those terms are not used anymore. So let's just talk briefly about history. In 2007, the National Kidney Foundation introduced the term diabetic kidney disease to replace diabetic nephropathy. Diabetic nephropathy being a biopsy term. In 2012, the medical literature widely recognized that many diabetic patients develop chronic kidney disease without clinical proteinuria. Proteinuria was no longer a rigid requirement for the diagnosis of diabetic kidney disease. The terms microalbuminuria and macroalbuminuria were discouraged in 2012 by KDIGO because the terms are misleading. So now microalbuminuria is now called moderately increased albuminuria or stage A2. Macroalbuminuria is now called severely increased albuminuria or stage A3. And then in 2022, the KDIGO updated guidelines explicitly discouraged using the term diabetic nephropathy, noting that it lacked a clear consensus and was considered outdated. Only approximately 10% of patients with diabetes mellitus and CKD go on to develop end-stage renal disease. However, 90% will suffer a premature death prior to reaching end-stage renal disease. For every 30% rise in albuminuria, the risk for cardiovascular disease increased by 17%, and the risk for all-cause mortality increased by 33%. A 30% reduction in GFR conveyed an increased risk for cardiovascular risk of 41% and 69% for all-cause mortality. The combination of both a 30% increase in albuminuria and a 30% reduction in GFR increased the risk for cardiovascular disease by 83% and the risk of all-cause mortality by 142%. The degree of albuminuria reduction from clinical trials has also been found to strongly associate with reductions in the risk for cardiovascular outcomes. So with diabetes, what you see on kidney biopsy would be thickened glomerular basement membranes, mesangial matrix accumulation, and then advanced accumulation of mesangial matrix would form Kimmelstein-Wilson nodules. The degree of albuminuria correlates with the glomerular basement membrane thickening. Rate of GFR decline correlates with the degree of mesangial matrix accumulation and resultant loss of glomerular filtration surface area. There's a parabolic, not a linear relationship between glomerular filtration rate and glomerular sclerosis, interstitial fibrosis, and tubular atrophy. Risk factors for progression of diabetic kidney disease include low nephron number, whether it's from fetal maternal factors or environmental factors, race, ethnicity, or socioeconomic conditions. Hyperglycemia and hyperfiltration are big risk factors for progression of diabetic kidney disease. Increased availability of vasoactive mediators will contribute to RAS activation, leading to reduced arteriolar resistance vasodilation and increased efferent arteriolar resistance vasoconstriction. Hyperglycemia stimulates increased proximal tubular glucose and sodium absorption via SGLT2 and SGLT1 uptake, reduced sodium delivery to the distal nephron, and subsequently reduced juxtaglomerular feedback and increased intraglomerular hydraulic pressure in single nephron GFR. And inflammation and oxidative stress is a big risk factor, not only in diabetic nephropathy, but likely in all glomerular nephritides, but certainly in diabetic nephropathy as well. There's some data on diabetic kidney disease and the gut microbiome. The hypothesis is that there's a reduction in anti-inflammatory bacteria such as Lactobacillus and Bifidobacterium genera, and that there's an expansion of pro-inflammatory proteobacteria. Both of these factors would then reduce the protective gut barrier characteristics. And in order to maintain a favorable gut flora environment, plant-based diets are recommended. These would reportedly reduce inflammation and mortality and improve kidney function in patients with diabetes. So, of course, the goal in diabetic nephropathy is number one, to achieve diabetes control, which is to have an A1C of less than 7, and then to prevent adverse outcomes of diabetic nephropathy, such as end-stage renal disease, progression of diabetic kidney disease, and sequelae of the chronic kidney disease process, such as anemia, bone mineral metabolism, and proteinuria. Generally, this requires a team-based, multidisciplinary approach with physicians, advanced care providers, pharmacists, nurses, dietitians, diabetes educators, and social workers. Probably the most important is to enforce lifestyle, to educate about lifestyle, to get the patient involved, to make the patient feel like he's empowered, he or she is empowered, and the patient is empowered. And pretty much success of the diabetic treatment approach is incumbent upon the patient taking responsibility for himself or herself. And lifestyle is the biggest part of that, whether it's weight loss, nutrition, or exercise. You want to achieve that A1C of less than 7.0. Every diabetes patient should be on RAS inhibition, followed by SGLT2 inhibitors, followed by finerenone and GLP-1 receptor agonists. Stacking is recommended, and all of these should be placed on the patient's medication list if tolerated or appropriate. That's the end of the board review series, as well as the end of this 8th talk in this board review series. Check out the rest of eNormous Nephrology at youtube.com/@irfanmoindeen-kidney. Send me a request for other topics you would like to see here. See you next time.